the annual conference chair for PhUSE this year. Before we get started, there are a few housekeeping rules to go over. All panelists, please put yourselves on mute when you're not presenting, and everyone else should already be on mute, so you don't have to worry about that. This session will be recorded and made available on the PhUSE Tube, and the slides will also be available to you. If you have any questions or comments during the session, then please post them in the chat window during the webinar, and then we will try to respond in the Q&A session. So the agenda for today will start with an update about the annual conference, and then we will have an introduction to the new real-world evidence stream by the stream chairs. And after this, we will have a longer presentation related to this topic, where Edith Heinz from Pharma will be discussing challenges of sequential treatment analysis. That presentation will be followed by a Q&A session, and then we will end the webinar with an update from the Computational Science Symposium in the US from last week, and then a preview of the first European CSS. So once again, welcome everyone, and we have a very exciting agenda and a full agenda. So let's move on to the first topic. The annual conference 2016 is going to be held in beautiful Barcelona. Barcelona is a lively city with an intense pulse. It has amazing architecture, great food, wonderful beaches. It is also very well located in terms of transportation from different countries. So if you haven't been to Barcelona, this is an excellent opportunity for you to visit. The hotel we have chosen for you is the 5-star Hotel Princesa Sofia. It is perfectly located in the noble financial district of the city, just one stop with subway from the city center and Rambla. And it's only a 5-minute walk away from Camp Nou football stadium and just 12 kilometers from the airport. So very well located. There are 500 comfortable and elegant bedrooms, and the conference facilities are perfect for PhUSE. It can take up to 700 people. So we may actually be having the biggest conference ever in PhUSE. And we also can look forward to a very nice outdoor beer garden that I expect will be very busy in the evenings during the conference. So the setting is perfect, and now over to the theme. The theme of the conference this year is fast track to approval, speed and efficiency. So the focus will be on time and efficiency. How can we standardize, automatize, design trials and utilize our data more effectively in order to reduce the time to approval? We have to find new ways to optimize the time and ensure quality, meaning that we have all the required deliverables in place at the right time. If we can achieve this, we have the opportunity to transform the business and help our companies. And we as data scientists are key in this process, so we should definitely take responsibility for driving the development in the right direction. In order to become more effective and be able to reduce the time to approval, we have to discuss pooling strategies, data standards, supporting softwares, programming techniques, statistics, and regulatory requirements very early in our project. For example, we can look at performance in our code to reduce the execution time, or we can look at providing regulatory agencies with analysis results metadata, which may speed up their review process. So there are so many things we can do if we just focus on time and efficiency. And this is what we're going to talk about in the conference this year. We have an obligation to do whatever we can in our area of expertise to ensure that we are on the fast track to approval. Everything that made PhUSE so successful over the years will continue in 2016 with some new influences. The streams remain the backbone of the conference. Inspiring keynote speakers will start each of the day of the conference. Interactive sessions open the floor for debates on relevant subjects. And of course, the conference remains a unique opportunity to network and share knowledge with colleagues and friends. This year, we will introduce 2 new streams. We already have 13 other streams. So this year we will actually have 15 streams. And the new streams are dedicated to real-world evidence and data visualization. The real-world evidence stream will be further presented later on in this webinar. So I will focus on the data visualization stream, which builds on the fact that a picture is worth a thousand words. So for centuries, people have depended on visual representations such as charts and maps to understand information more easily and quickly. We collect massive amounts of data during the course of a clinical study, which cannot be digested by just looking at tables and listings. So we have to do something else. And data visualization is a powerful technique, not only to communicate with scientists, but also to understand, interpret, and even clean the data. So this stream will focus on examples, tools, and techniques which can be used within our field to represent data better to support drug development. So that's the news about the streams. This year we are again running a scriptathon, which is actually more a contribution to PhUSE session, where any member who is interested in doing some hands-on work to support PhUSE is welcome to join. It will take place on the Sunday afternoon before the welcome event and poster session. And the ones attending can expect to help out with coding, working on our wiki, or some documentation, or just helping out with organizing PhUSE material. So it's a very nice way of getting to know people and also feel that you contribute to PhUSE in a relaxed setting. This year we are running 6 really interesting workshops. So we have one focusing on good programming practice, one on semantic technology. Then we are running a workshop on R. We also have a CSS discussion club, and then a CDISC workshop named Exploring the Potential of Standard Clinical Metadata. And we will have a final workshop from SAS. So lots of interesting and interactive sessions where you can learn and contribute. We can already now present 3 very inspiring keynote speakers. On the Monday, we will be visited by Alok Jha, a journalist, author, and broadcaster focusing on stories about science. On Tuesday morning, we will hear from Dr. Aseem Malhotra, one of the most outspoken cardiologists in Britain, who is currently leading the campaign against excess sugar consumption. And finally, on the Wednesday, Dr. Jack Lewis will give a presentation. Dr. Lewis is a brain scientist, writer, television presenter, motivational speaker, and neuroscience consultant. So I'm very confident that all 3 keynotes will provide great inspiration and motivation for us all. You can find more information about the topics that will be presented by the keynote speakers, and also more about the background of each of the speakers at the PhUSE webpage. Okay, so some final words, some key dates and events happening in the planning. Already now, most of the exhibition stands and sponsorship opportunities are taken, but there are still some options available. So if you are interested in any of this, then please contact the PhUSE office. The conference registration has already opened. People are starting to register. The hotel is available for booking, and you should definitely register early this year, since the conference has sold out the past 3 years. Most importantly, the call for paper system is also open, and it closes on April 29, so that's just about 1 month from now. And we in PhUSE encourage all new and experienced speakers to submit an abstract. The more abstracts we can choose from, the better variety and quality the conference can provide. And presenting is actually very fun, and it provides a great opportunity to share and discuss your ideas, challenges, and experiences in work life. PhUSE is a great place to present. It's very informal and friendly setting, so don't hesitate to submit an abstract. We would love to hear from you. October, we're all very much Lona, and perhaps also to present. So with that, I will for the new real world team and the next presenter. Hand over to Knut and there we go. Over to you, Barbara and Knut.
Yes, hello. My name is Barbara Snoeja. I am the stream chair of the Real World Evidence stream. Together with my co-chair, Knut Muller, I would like to tell you more about what our stream is about. After that, my colleague Edith Heintjes, a farmer, will give a presentation that fits perfectly within our stream. So what is real world data about? Can we get the next slide? Okay, so it's about claims databases. Maybe you can put everything, medical charts, observational trials, so a lot of things, but also about social media registries. Actually, it's any data that is generated not for the purpose of doing research, but just in daily practice. So like for observational trials and registries, those data are registered for doing research, but it's not generated for doing research. So next slide, please. What is real data used for? There are many things that it is used for, like cost analysis, planning of clinical trials, support of benefit risk analysis. So a lot of things that we can do with this data and many more. Next slide. So there are many challenges with using big real-world evidence data. Often it's a real big data set, so it's not about 10 or 100 or 1,000 records, but it's often about millions and millions of records. And also you have many variables. The size of the records often give a heavy burden on the systems, and it costs much time to go through them. So you must know what subset of data you need and which data is eligible to use. Also, the variables that you are using, you must know, are those the correct variables? Are those the variables that I think they are? So are they also collected in the way that I think they are? Data are, in most cases, retrospective, so that means that you cannot add variables that are not collected in the past. So that's challenging as well. And also there are many inconsistencies in the data collection. So there might be data missing or not collected at all. So, and you don't know why data is missing. So for example, if you don't have a lab measurement, then you don't know whether it's not taken at all or that it's not registered. And one of the other challenges that I noted here as well is the linkage of different databases. So one database alone is interesting, but if you can link them to other databases, then it's much more interesting, because then you can link data from, for example, a GP to data from the pharmacy to data from the hospital. So how do you do that? Do you have a numbering of patients that match, or do you have to link them on another way? So that's challenging as well. So there are many things that you can think of. Knut will go on now to talk more about what could be topics in the real-world evidence stream. Yeah. Knut?
Yeah. So the The potential topics for the real-world evidence stream are around these three fields. Why do we do real-world evidence studies? What do we do? So it's all about study designs and how do we do that? What methods are applied and the challenges that are around these methods. With regard to the purpose, Berber already mentioned by the studies, it certainly helps the reimbursement negotiations. Comparative effectiveness when you compare treatments where you might not have clinical trial data, but also to compare them in a real-world setting without the artificiality of a clinical trial. You might need support your benefit-risk analysis with real-world evidence data, and to prepare clinical trials, to check what patients you might get for a clinical trial and where they sit and what sites might be appropriate. This is also interesting, or a purpose that is getting more and more important. And not to mention things like detection of off-label use and to generate new indications for a certain compound. When it comes to study designs, this is the whole world of the epidemiology, but not only. So there might be case control studies, matched cohort studies, but also cross-sectional analysis. There might be guidelines and best practices with regard to that. When it comes to methods, there as well, this list is not comprehensive. With regard to have comparisons, as there is no way of randomized treatment groups, you have to deal with matching algorithms. You might even have to do a propensity score matching. Incidence and prevalence estimation is one big topic that requires certain methods, as well as time to event analysis and competing risk analysis. One big challenge is dealing with sensor data missingness, and there's a whole world of sensitivity analysis, as you have to check your assumptions that you have to put around using real-world evidence. And of course, although it's not standardizable as in clinical trials, there are a lot of attempts with regard to standardization. So we are looking forward for you to submit an abstract to our stream. And I would like to hand back to Berber and Edith to hear a presentation about the challenges of sequential treatment analysis.
Okay, thank you, Knut. Just to remember, if you have any questions during the presentation, you can type your questions in the chat room, and then we will try to handle them after the presentation of Edith. If she gets the screen, she will start with her presentation.
Okay, thank you very much for the introduction. Yes, as we just talked about, we can now move on to the webinar with regard to the challenges of sequential treatment analysis as an example of the things we might submit to this conference. The contents quickly of this presentation will be, I will be answering questions of why you would be interested in doing sequential treatment analysis. Also, we will review the considerations when you are creating drug treatment episodes. Also, considerations for combining treatment episodes on an individual level, and then the challenges of trying to visualize your data on a population level. We will go into several aggregation considerations and display options and the challenges around them. So why would you assess sequential treatments? This is not an exhaustive slide. I will just touch on a few things. For one, we can look at the determination of specific treatment episodes on a patient level. And this means that you are defining periods of your drug of interest that you're studying, and possibly some concomitant drug use that is also of interest for your study. And if you have this patient-level data, you can also expand that to look at treatment patterns on a population level. And then we're talking, for example, for not just that cross-sectional data over time, but actual switching patterns taking place within patients and proportions of patients making those switches. So I'm going to take you through a stepwise approach of doing this sequential treatment analysis. First, usually you start out with a data set that just contains medication records. It's got a patient ID, a date, hopefully an ATC code, but that would not always be the case. But most importantly, there must be some indication of how much of the drug is being prescribed, and how long it should take to actually consume that prescription. So what we would like to do is, step one, determine per prescription the duration of its use. And the next step would be to determine individual episodes of that drug of interest. Combine any episodes of the drugs that you have analyzed on an individual level, then apply possible corrections in case of switches. Then you can create some transition tables to have an overview of the population level, aggregate and display the results and in the end, and then hopefully we will end up with some kind of visualization of what's going on in your population. So I will now go through all of these steps in the following slides, and hopefully I can take you through all the considerations there. First of all, let me start by defining what I mean with a treatment episode. An episode, in my definition in this presentation, will be a period of uninterrupted drug use. You can look at that at different levels. One of them would be to have an ATC code, which would mean that you're looking at the actual compound in a drug. It can be a brand, it can be a generic. So we're talking about the generic drug name here. But as I said, you can look at different brands or a brand versus a generic drug and look at switching patterns going on between them, which might be of interest. And you can even go deeper. You can look at dosing. So you can look at titration patterns if you can define how long a patient is using one specific daily dose and then switches to a higher or a lower dose. That might be of interest as well. On the other hand, you can also go up a level and not look at the individual drugs, but at whole drug classes to have a broader view of what's going on in a specific disease area and what type of drugs people are using and how the switching between those types of drugs is going on. Back to the patient level, you have to understand that a patient may have multiple drug episodes, and those episodes could be of the same drug because the use is interrupted between episodes, or it could be of multiple drugs where you can look at the sequential switching between different drugs, or you can look at simultaneous consumption of drugs. So step one, how do we define the duration of a prescription? You can base that on the dosing description, and I have an example here where we have 90 tablets, and the dosing description would be 2 tablets per day. Then you end up with a duration of 45 days, and I will be representing any durations of prescriptions in this whole presentation as arrows. An alternative method would be to base it on the daily defined dose as recorded by the WHO. Then you might have, you could use the assumption that everyone is just using 1 DDB, which would mean that they always use the average dose, 1 per day. Or you could have an analysis based on dose equivalence if you know that the tablet strength does not match the DDD strength. So that could possibly give some challenges in determining the duration of your prescription, but that is up to each database owner to decide what is appropriate for their study question, for the specific drug they are studying, and also for their data. Then let's move on to step 2. How do you create individual treatment episodes? Let's just focus on one drug for now. You can imagine that in practice, people don't get their new prescriptions exactly at the time that their old prescription ends, because for practical reasons, you could get an early refill just because you don't want to run out of the drug and you have a busy daily schedule, so you go to the pharmacy early, or because you go on holiday and you come a lot earlier. So what can happen is that you have overlapping prescriptions in your real-world evidence data, and you get overlaps and resulting gaps between prescriptions, because the next prescription can be a lot later before the patient comes in to refill it. So in reality, patients will start the medication after the first prescription is consumed, and then you have to shift the date of the start date of the overlapping prescription to the end of the prior prescription. This sounds easy enough, but you have to set a reasonable limit to the shift allowed, for example, a maximum of 30 days, because you may have some miscalculations in your durations and you don't want to exacerbate the problem by, instead of just making a reasonable shift, making the shift to the end of the prior prescription and then overshooting the next prescription. So if we are talking about gaps, you might fill them just by shifting some prescriptions, but still you might end up with remaining gaps. You should have, you should just allow small gaps, because for clinical reasons it makes sense that they exist. For example, a patient is not completely compliant and once in a while they forget to take their medication, and that means that the duration of a prescription may stretch a little bit. Also, it can be that during the consumption of one prescription, a patient experienced some adverse events. They go back to their doctor and the doctor says, wait, maybe you should just lower the dose and then continue with the same medication, but it takes longer before it's consumed. Also, it could be that patients are hospitalized for a short time and that they receive their medication in hospital. So for this period, you need to shift the remaining medication at home. For practical reasons, you really do want to allow some gaps, because if you end up with too many episodes, it's impossible to interpret your data in the end, and it may not reflect what's going on in real life. For individual treatment episodes, we already talked about the permissible gaps. Well, how do you do that when you do your analysis? The easiest way is just to add a grace period at the end of the prescription. So you could basically extend the prescription to maybe, just as an example, half the duration of the prior prescription. And in terms of short prescriptions, that may be a bit not enough. So you can also choose to have some 7-day extensions, or any chosen fixed time. Now, these gaps are represented in this graph as white arrows. The white arrows are just to show the permissible gap. That's not the actual gap, but just the permissible gap. The blue arrows represent the prescriptions, and now we see that the small gap between the first two arrows is actually bridged by the grace period, and we talk about 1 episode of uninterrupted use. Then there is a bigger gap, which actually exceeds the permissible gap. So then we say, okay, this treatment was actually interrupted, and then we start to have a new episode of drug use after a while, which would be episode 2. Now, if we talk about this grace period, you can have the issue of what to do with this grace period at the end of an episode. You can actually choose to always include this grace period because you assume that there will always be some non-compliance, and you assume that the whole prescription is used. And then you add it at the end. You can also say, no, I don't want to add it. I do want to give it some leeway just to make sure that I don't create gaps where they don't exist. But if they exist, I just want to stop the use exactly at the end of that prescription. So then you assume that they are completely compliant and they also consume the whole prescription. Or another approach would be to actually halve the duration of the last prescription. Now, what is the reason for that? The assumption would be that the patient is going to stop their medication. So if they are not motivated to take their drug, maybe they will stop it a lot earlier than just at the end of the prescription. So here you assume actually that some patients will never consume it at all, some will consume it all, and some will be somewhere in the middle, so you take the average of just half the duration. That is up to the researcher to decide what is the appropriate definition. It will also, of course, depend on what you're actually researching. If you're taking antibiotics, it may be very acceptable to always that everything will be consumed and patients will be completely compliant. Whereas, for example, if you're using statins, patients may not be that motivated and you may want to halve the prescription. If we then move on to step 3 of combining episodes, we're still talking about the individual level. You can have, let's just take an example here because it's becoming very theoretical at this point. Let's just say that you have drugs with a similar therapeutic action, for example, glucose-lowering drugs for diabetes. You can have an episode of drug A, and somewhere during that episode, there may be another drug that's been added to increase the effectiveness of treatment. So for an add-on, you assume that there is a continuation of an existing drug and an addition of a new drug, in this example, drug B. So the technical definition would be that the start of B is before the start of the last prescription in episode A, and then we assume that they are taking both drugs. On the other hand, you might also look at switching between drugs. I added a drug C here that actually starts after the last prescription of episode B. So C is added where B is discontinued, and then we talk about a switch. So if we're talking about switches, it may be appropriate to start correcting some episodes of certain drugs. So if you have overlapping episodes, as in this example, you have combined use, or is it just an alternative medication? Let's look at this more closely. If we just divide it based on what's used during a specific time frame, then it seems that we have 4 episodes here. But does episode 3 really exist? that depends on the clinical background and your definition. Does drug C actually replace drug B? Or can you assume that they are using it at the same time during episode 3? I would suggest that you look at the action of the drug and make sure that if it is a similar action, you actually correct the episode of drug B and you stop the use of drug B as soon as the drug C is started. I would not recommend doing this in case you are looking at different drugs for the same condition, let's say, for example, COPD, but you have airway you also have drugs to suppress inflammation. Then you do assume that they're used at the same time and that there is no switching going on. So make sure you always know the clinical background before you start correcting episodes. And then you end up with just three episodes instead of 4. And that will avoid short and unlikely episodes in your analysis. So let's get back to the question of why we wanted to assess this at a patient level. Well, you might use this to start matching patients to find patients with a comparable treatment background, starting a new drug. This would be useful if you were doing an effectiveness study or any other type of outcome study, where you will compare, in this case, the orange and the green drugs, but you want to make sure that they're at the same point in their treatment path, and therefore you require that they have the same or a similar history of drug use. So you can also use it then to determine the follow-up of this outcome study. And you can use it to actually serve as the outcome of a study. For example, if you're looking at persistence or time to treatment change. If we're looking at time to treatment change, then we can actually already make an excursion to the population level analysis, because you can imagine that you could do a survival analysis where you look at the different drugs and how much time passes before they actually have to switch to yet another type of treatment. So if we're looking at the population level, then again we can ask, why would you want to do that? Well, sometimes it can be useful just to do an assessment of the market to see where a new drug would fit in. That would be appropriate prior to approval of a drug, to see what's actually going on, and if you're trying to find out how it will be most likely used and how it will be reimbursed, then this might be very useful. But also, after it's been introduced on the market, it might be useful to have an idea of how it's actually used in the real world, as opposed to what you planned how it would be used. It may not always be the same. And also, you can use it to see whether your assumption about the guidelines on which you base your decisions are correct. Does the real world actually reflect what's in the guidelines? Sometimes we look at the guideline, we see that there is a first-line treatment, a second-line treatment, and a third-line treatment. And it usually, in the case of diabetes, it would assume that the intensity of the treatment escalates over time. But in the real world, we see that the intensification of treatment is also taking place, or patients are even taking drug holidays, where you would not think of that if you didn't really look into the data. So then we come to step 5 in our process, where we look at the population level, and we have some challenges here. The challenges for the presentation of change patterns. You can have diverse timing of changes in treatment. They can start at a different point in the calendar year, of course, but also after they start using a drug, the time to the next treatment differs among patients. You may have a large number of treatments and treatment combinations to look at, and you have a varying number of treatment changes in the study period. Or, yeah, altogether it will lead to a large number of possible patterns, of course. So when you start doing this type of analysis, you need to consider upfront whether you're looking at a specific type of drug in comparison to others. Then you're looking at inception cohorts that can start anywhere during a long study period. You can also have a study where you're interested in general changes in treatment over time, where you would look at calendar years. But anyway, with any type of longer duration of a study period, you have to account for attrition, because if you start later on in your study period, you will have a shorter follow-up. And then this attrition needs to be considered carefully, how you will interpret that in your study results and in your graphical presentations. So let's just go through it step by step. Population level, any change that's taking place or any time point that you want to analyze in your data, you can create transition matrices, which means that in the left-hand column, you would have the prior treatment, and in the columns at the top is the treatment that they end up in the next state. And this next state can be the next treatment, or it can be the next time point. If it is the next treatment, then you will see that on the diagonal, you will have empty cells, and the cells actually represent the number of patients that go from one state to the other. If you look at it for predefined time points, some patients may not change at all, and therefore you will see that the diagonal will be filled with numbers. But this is something that you need to consider, how you want to present your data and what is interesting for your study question. You can see that these tables are already becoming quite complex if you're just looking at 3 drugs, because you have no treatment, mono treatment, dual treatment, and triple treatment options. So imagine what happens if you're looking at disease like diabetes mellitus type 2, then you have different drug classes, and each class contains 3 to 14 drugs. And then in the Netherlands, for example, there are 20 to 25 drugs that are actually being used at the same time, and this may result in transition tables that have 150 or more combinations of treatments that actually occur in real life. So you need some way to aggregate those data. I will continue to work with this simple example, but this is just an example to show what I mean with aggregation. If you just want to look at the level of the number of drugs that patients are using, this is a simple way of producing your data, just by looking at whether it's mono, dual, or triple therapy. But there are, of course, many other ways. So there are a few considerations if you want to decide what type of aggregation would be appropriate for your study question. You can look at individual drugs in a class, but this is only appropriate when you have a limited number of drugs, because otherwise you get the situation becomes too complex. Also, you can look at this mono, dual, and triple therapy, as we already discussed. This can be used to simplify a situation where you have many drugs, but of course you lose any information on the individual drugs, and that might not suit your question. So if you can reduce it to this simple amount of to this simple way of representing things, or just a limited number of drugs, then you might consider a tree flow diagram where you can actually follow each patient in time and see where they end up. And in this flow diagram, you would, of course, add the percentages of patients in your population following a certain path. You can only do this if you have a few possible paths and a few time points. You can also look at the class level analysis. If you do that, then you have to consider whether each drug is interchangeable within the class, and because you need to decide whether you need to shift or maybe correct episodes of specific drugs. And this, of course, depends on your clinical assumptions behind it. So you have to really go into the reasons behind your data. You can do this if you have a limited number of classes, but many drugs per class, and then, of course, the class level information has to be informative to your question. Do you need further aggregation of class combination? What kind of further aggregation can you think of? You can think of just showing the most frequent drug classes, but then you have to consider at which time do you measure that frequency. You can base it on the interest of your question. Maybe the most infrequent drug is the one that you're actually interested in, then frequency is not an option. And based on clinical aspects, you have to think of whether some classes may have some kind of special status that you always want to show them. For example, insulin versus oral anti-diabetic drugs. So what do I mean with the timing of the frequency? This is a representation of what can happen if you look at an inception cohort. This specific inception cohort would look at the initiation of insulin treatment at time 0. You see that the classes prior to that time point are, of course, very different than the classes after that time point. So the frequency will be non-existent in the first year in this presentation, and it will always be present in the rest of the follow-up. Also, it may be that the most infrequent drug is the one that you're actually interested in, and then this type of representation wouldn't work because it's completely lost in these data. And you have to find some way of making it show up. And also, it can be based on the clinical aspect, as I discussed before, that some classes may have a different status. So what other types of representation can you consider? Well, if you're looking at this type of representation, this is just a detail from a larger graph. I'll speed up now. The before is what we're actually looking at here. We have combined the mono and combination therapies to make sure that the numbers go up and you can actually see it in your representation. So if you want to look at individual drugs within classes, then you might want to consider a mixed drug level and class level analysis, where you have to make sure that the individual drugs show up when you want them to, and for the rest of that drug class you need to decide whether you want to see those individual drugs or that you're just interested in the class. This is one example of that, where we used specific drugs, and in this case, this would be glibenclamide. In this river plot, you have to consider each column of percentages as a specific state, and all the lines going between those columns are the transitions that you could find in your transition tables. Here you can see the proportions going from one state to another, and you can follow them over time. Another way of showing that type of data is by using Sankey plots, which can be interactive. And if you just hover your mouse over the graph, this is a static picture because otherwise it wouldn't work in my PowerPoint. But if you hover over the transitions, then they light up and you can see the actual proportion of patients included in that transition. Or if you point at a specific column, you can see how many patients are in that specific state. So this is my last slide. I'm summarizing it now. The accuracy of the duration of prescriptions has to be compensated by gaps, so make sure that you make the right decisions. You have to combine the use of different drugs, and you have to make sure that you correct for any inconsistencies or treatment episodes that don't really exist. And also, you have to make sure that you choose your aggregation methods very carefully, and always consider the research question and changes over time, as well as clinical aspects. And consider whether the path, the time window, or both should be represented when designing a transition matrix. So make sure that you highlight what you want to see. And consider with graphical representation which is the best to get your message across, of course. So thank you very much for your attention. I will now be answering any questions that may have arisen.
Okay, thank you.
Thank you, Edith. That's what we have received a couple of questions from the audience. So I will start with the first question, and I'll read it to you. Are you aware of anything that?
Yes, actually there is such a source. For example, there is an NCEP organization. This is an organization that tries to list all the data sources available for real-world evidence studies. It's called, it spells like ENCEPP. It was actually set up analogous to the trials registry, but this time for observational studies. And I believe it was the EMA that instigated this source. It also lists all the past studies going on, so the post-approval safety studies and effectiveness studies. So you can register those studies online, similar to the trials registry, but it also contains a list of all the data sources of organizations with available data for this type of studies.
Okay, thank you. Another question is, can you give an example of a commonly used real-world evidence data source?
Well, yeah, I'd have to say the PhRMO database, of course. I'm working for the PhRMO Institute. This is the core business of this institute, to perform those studies based on real-world data. So we actually do link data from different sources, such as pharmacy data, hospitalization data. We also have primary care data, and we have clinical laboratory data, and can use it all to link it to the cancer registry.
Okay, thank you.
There are multiple examples of these types of organizations, but I have to refer back to that source that I just mentioned. And we also work together with a lot of partner databases in other countries. So we can always, especially if you're looking at rare events, it's always useful to look at multiple countries, because, of course, data can differ per country, incidences can differ, treatments can differ, and we can combine our sources to make sure that you get the best answer to your questions.
Okay. Thank you. I don't think there were any other questions for you, Edith, but there was one question about the annual conference, and that question was, when will decision on paper selected be decided? So The call for paper closes on 29th of April, and then the stream chairs have a couple of weeks to review all the abstracts, and we will meet on May 24th to decide on which papers to include in the conference, and by end of May all the presenters will get information about acceptance or for the paper. So by end of May, all the ones that have submitted an abstract should know if they can make it to the conference. And we do have some more slots this year, so hopefully most of you will have a good opportunity to get your paper selected. That was all the questions we had. So I think we can conclude the Q&A session and move on to the CSS conference update and the preview of the European CSS. So I'm handing over to Chris Decker and Scott Balavuni, who will be talking about this.
Okay, I will change over to Chris now.
Thank you.
Okay.
Hi all, this is Chris. Can you hear me and can you see my presentation? If someone gives me an acknowledgement.
We hear you and see your presentation, Chris.
Okay, great. Well, thank you. I've got a lot of slides here today. Bear with me while I get set for a minute. I've got a lot of slides together. We tried to put together quickly slides following the Computational Science Symposium, which just happened last week. So as you can imagine, trying to pull together all that information from all the great work that was done took us a little bit of time. So I'll be going through a summary of the meeting last week and giving everybody an update. And then I will hand it over to Scott, who will give a bit of a preview for an upcoming event we have in Basel, which is our first foray into bringing the activities that the Computational Science Collaboration is working on to Europe. So I just want to quickly go through a quick overview. I do this on most presentations just because I never know who's watching, who's attending, and might not know a bit about this collaboration. So the idea here is now 5 years old. It's amazing it's been 5 years. Was that the FDA and PhUSE and others in industry wanted to stop going to events where there was presentations from regulatory agencies and we would just ask a question or two about the topics. We really wanted to sit around a table and work on these issues together. So that was the starting point or initiation of this collaboration. And I'm not going to read the text here, but the overall theme is that the collaboration is about being transparent and non-competitive. So bringing everybody together to work on issues, gaps, new opportunities to support the product development process. And it's really a simple collaboration. It's made up of the symposium, which occurs every March in Silver Spring, as well as the working groups who meet throughout the year. So those things combined make up the computational science collaboration. So sometimes you'll hear the computational science collaboration, sometimes you'll hear the symposium, the CSS. The symposium is the event that just took place last March in Washington, D.C. And the working groups are actually made up of 5 different working groups, all governed by a steering committee. So we have a steering committee that's made up of liaisons to the working groups, 4 additional industry members, as well as 4 individuals from the FDA are part of that. And these are the 5 working groups that we have. And I'll touch quickly, and I'm going to go through very, very quickly, so I apologize for the speed. But I will touch on each of these working groups and some of the activities that they engaged on last week. So I do want to start with a couple of slides. We implemented a new tool at the conference, which you'll see in future PhUSE events, that'll let you basically take poll from the audience in real time and displays those results. So the first poll that we did, or question that we asked at the end of the conference was, well, first of all, I'm getting ahead of myself. Let me just go through quickly a couple of highlights. We did have over 300 attendees, so in our facility that we have this event, that's what we can have, and we sold out a few weeks beforehand. We had over 50 FDA attendees. So this is a great collaboration that we have, and this event was a co-sponsorship event with the FDA. And so over 40 individuals from various groups within FDA came, engaged, and really got involved in the various working groups. And we also had two, we were excited to have two guests from PMDA come and attend and just sort of absorb the information and the content that was going in. So we've moved to a global organization, PhUSE has, and it was good to have those individuals there and participating. Lively panel discussion that we had among industry and standards and FDA on Tuesday afternoon. And we really had engagement in every project. Every project was working, engaging, and really moving forward. And it's always an opportunity to network with new and old colleagues, and we always have great food, which is obviously very, very important to keep our brains moving along. Back to the question and polls that I was referring. We asked at the end of the meeting, who will join and really contribute to these projects as they move forward? And I'm going to be the statistician and play with the numbers and say that 95% of the people there, which is statistically significant, said that they weren't sure or would participate in the project. So again, a lot of engagement, a lot of involvement in these efforts. The second question that we asked, which was an open-ended question, was what word or words describe this event to you? So they had just spent 2 days engaging with working groups and really working with their colleagues. And we asked that question in the closing session. And we found it very amazing that the word that really came up, and this is a cloud for those that don't know this type of thing, is as a word gets put in more and more, it gets bigger and bigger. So you'll notice the words in here were collaboration, collaborative, informative, engaging. So these are the words that people put onto this question, which talked about the engagement and PhUSE as a whole. I do think it was interesting that in addition to collaboration, there was Guinness and burrito. So we like to collaborate, we like to eat, and we like to drink. So I thought that was very humorous. But again, the collaboration among these groups is really important, and I think that's something that came out of the meeting. So I'm going to quickly run through each of the working groups. So the Optimizing the Use of Data Standards working group is focused on how best to use the standards and closing any gaps or implementation issues that we have. And we work very closely in partnership with CDISC in providing this information back and having CDISC liaisons as part of the projects within this working group. So some of the things that they worked on in the meeting, and again, you could read through all this, but I'm just going to quickly touch on them, is partnering with CDISC to look at implementation nuances in the standards as you talk about different versions, really looking at how we capture that and talk about best practices. A group that wants to focus on the defined version 2.0 implementation, how to implement that, what are the best practices customers doing in the field, and the study data standardization plan, which is a document that's referenced at a very high level in FDA, is something that a team is working to put together. And there's an FDA champion, as they call it, that's been identified, or send it through the proper official channels to give input into that document. There's a legacy data conversion plan and report of how you handle legacy data conversion, and an updated standard data reviewers guide will be sent to the FDA PhUSE working group to take a look at. The differences between the reviewers guide and the defined.xml. There's a lot of information that gets shared with the FDA. The FDA was very adamant at the beginning of their opening session, but the reviewers guide, which is now a data that they would like to see in every submission, has been extremely helpful for them in their reviews. And so this group is looking at making sure we don't have a lot of overlap, or where we do have overlap, it's okay. So they're looking at sort of best practices around that. And then one around standardizing data within the inspection site process. So if I move on to the standard scripts for analysis and reporting working group, again, this group has a number of projects that are ongoing. What did they do on in this specific meeting? Well, they got together and they talked about some of their white papers, specifically a few of them that they've been working on. Had some breakout sessions to work towards finalizing those white papers. And deposits and qualify with the FDA rapidly get up to speed with their submissions. And the FDA has supplied a lot of their script working group is to continue to partner and promote the Jumpstart content. And we're having some conversations with leverage the needs that they have and develop scripts that can support them as well as industry, as well as working on and moving forward. And finally, some possible new projects. One of the areas that they struggle with is they to move through. So there's an interest in building a group around developing test data specifically around the CDIS standards. And then mapping the white papers into scripts. So really creating some technical documents to support the white papers that are being published. The non-clinical implementation and roadmap, again, one of our strongest groups that has been working from the beginning of the collaboration 5 years ago. They had an incredible attendance, their largest ever, over 60 attendees from FDA, PMDA, and other groups. And they have 9 project teams that will actually go forward into this coming year, and I won't kind of go over those here. They collaborated on a poster award, or they had a poster award for their collaboration of their non-clinical SDRG, and then an assessment of the current state of SEND readiness in the industry. So there's a good paper to publish out to the industry as a whole. And a lot of conversations about data visualization and analysis with other working groups. So the collaboration is within working groups and across as well. The SEND implementation, that group continues to move forward and continue to build upon what they've already put in place. And then again, visualization and analysis are looking at a number of groups and projects within that space. The emerging trends in technology, again, this is an incubator working group, so new ideas come into this group and they incubate them, and if they are something that a group is excited about, they move forward. So we had 5 projects either continue or start up in this effort. The first is at looking towards what an alternative transport submission format might look in the future. A lot of conversation about the type of transport format as well as the content that is actually in it. So they have some plans to move forward and always need new ideas from folks who would like to join these teams. The cloud adoption, this is one probably that's kind of different from our normal things, but has been very well received by various organizations, including EMA, is looking at how we adopt various technologies and processes in the cloud and do that within our umbrella of regulation. So a lot of work being done in this group, and they have some excellent deliverables in terms of white papers and framework for how to do this. Data Transparency Group, another working group, not directly connected to the computational working groups, but we've included in this meeting, and they did a lot of good work around reviewing the EMA policy, as well as looking at ATOM. So they published last year the SDTM de-identification rules, and now they're looking at ATOM and how to look at defining rules around that. A group around data visualization, they're looking at different targets for visualization and how to focus on trying to come up with good use cases for this and move it forward. And then a statistical computing environment group. This is one that looks at developing, or has looked at developing a framework for describing user requirements, and then look at some next phases of defining and maybe sharing those requirements and needs across the industry. And finally, the semantic technology working group. This is one that's looking at various things. They did a great workshop here, and we're going to follow that up with workshops at other PhUSE events, where it was really the goal here was to give an introduction to semantics because it comes across, again, a lot of times when you hear this, it's very technical, very complicated for some that don't have the background. So the goal here was to provide an introduction to this concept and how you can really apply it to the clinical data that we work with every day. We had planned for 30 attendees. We had over 50. The room was full, and there was a lot of interest in this. So we will have future offerings of this at the PhUSE EU event as well as the annual conference in Barcelona to bring people up to speed on this technology and how we can leverage it. Analysis results and metadata. So this group is looking at a white paper around how to model analysis data, and is developing some white papers and a final set of technical components to this project. The clinical program design is looking at developing a white paper for how to model out the end-to-end clinical program, and then look at tackling some very specific components of that program design. There's a group that has a lot of interest by FDA, so one of the co-leads of this project is actually Mitra Roca from the FDA, that wants to look at how to take their regulations, which are all in PDF and paper documents, and really model those regulations so that they can be machine readable and be used in various different ways. So they're looking at different tools to use for that and how they might be able to model that information. So this is a very interesting project, I think, is taking PDF and documents and actually putting it in a model. And then finally, one that was initiated shortly before this event, but got some energy behind it, is really looking at how we link our data across the spectrum and how do we model that and define the use cases. So the first step of that is really defining use cases for that process. And there's going to be a few virtual roundtables coming up this year and a collection of those use cases and potentially the development of a proof of concept along with both some of the other projects within this working group as well as some of the other working groups. So I ran through that at breakneck speed. If there's more questions, I encourage you to get engaged in the projects through the PhUSE Wiki and other avenues, or feel free to send a request or a question or two about the things that went on. We will be having in April or at the end of April another webinar that's focused where the working groups will actually come on and provide a much more in-depth overview of the different groups. This was sort of just a quick summary of last week's meeting. So I'll hand it off to Scott Ballouni, who will talk about the upcoming European CSS.
Thanks so much, Chris. So do you want me to take the presentation rights, or is that something that you just want to skip through the slides for me?
Why don't we just you do the next slide, and I'll be the next slide in person.
Sounds good. If you want to go to the next slide, then. So as Chris mentioned, this was the 5th year that we've executed the CSS in Silver Spring, Maryland. And as Chris and I were having our debrief after the meeting, we kind of noted that the last 2 to 3 years have run really well. First couple years were a little challenging, kind of getting the collaboration started and getting the working groups moving forward, but the last 2 to 3 years have just run very smoothly. So there's been some discussions within PhUSE about doing a European event. So in June of this year, we are taking the CSS and traveling to Europe. So if you want to go to the next slide, Chris. So why a European CSS? So collaboration and innovation that are kind of the hallmarks of the Computational Science Symposium and the collaboration as a whole, they're not just limited, they're global. So taking those ideas and moving them across the pond and trying to get more of a global presence behind some of the working groups is in my opinion, an excellent idea and path forward. We actually have a lot of European colleagues that are making significant contributions to the CS collaboration. We have a few that sit on the steering committee that Chris had mentioned earlier in his presentation. We have quite a few that are leading both working groups and projects within working groups as part of the CS collaboration. And an informal poll, we didn't use the fancy polling technology that Chris had mentioned on his slide, an informal poll of hands at the 2016 CSS, approximately 20% of the folks attending the US meeting are actually based in Europe. So again, moving it and having an event in Europe just seems to make logical sense to those of us involved in the collaboration. So if you want to go to the next slide, Chris. So what can you expect as part of the European? Again, it will be June 21st and 22nd in Basel, Switzerland. It's focused on a subset of the working group projects that Chris had just presented. And it will actually be a free event to all PhUSE members. There are only 120 spots available, so your registration space is limited. So we will open registration on April 1st for working group members. So if you are participating in a working group, regardless of whether you're located in the US, Europe, Asia, and you want to attend this event, please register early. And again, registration for working group folks opens on April 1st. So assuming that we don't fill all 120 slots from working group members, we will open this to the general public in mid-April. So we're still the April will actually open a few weeks after registration for people that are currently participating in working groups. So with regards to the agenda, if you wanted to go to the next slide, Chris. So we'll have a half-day session on Tuesday and a full-day session on Wednesday the 22nd. The half-day on Tuesday will be an opening session with a few keynote speakers, and then the working groups or the projects that are actually being run at the European CSS will kind of break out and do some introductions. And then the Semantics 101 for Pharma workshop that Chris mentioned that we ran successfully at the US CSS will be run here at the European event. So then all day Wednesday will be spent on project breakout sessions and to kind of continue the work that's been ongoing at the US event, as well as it's ongoing throughout the year within each of the working groups. And then there'll be a wrap-up session and some closing remarks as well. So if we go to the next slide, we'll get an overview of the projects that will be meeting at the European event. You know, as Chris showed in his slide, there's a lot going on in the computational science collaboration, and to bring all of the projects to a day-and-a-half event would just be quite a challenge. So we decided to break down and identify a few projects that have a strong European contingent, so that those of you that are local to the event or on the continent, you can are actively participating in these projects. It's again an excellent opportunity to continue the work that occurs throughout the year. So the first project, and Chris mentioned this on his slide, is this SCE experiences project. And again, what that project is focusing on is information sharing across industry and regulators around statistical computing environments. And at the European event, this project will continue to explore what are the ideal requirements for a statistical computing environment. Another project that will be meeting at the European event is the alternative submission transport formats. Again, this project, as Chris had mentioned, is looking to address some of the known challenges that we have regarding the SAS version 5 transport format, which is currently required by the FDA as part of a regulatory submission. This project is exploring a different format types, and at the European CSS, what they're looking to do is finalize some evaluation criteria and develop a survey that can be put out and circulated to regulatory and industry stakeholders to the transport format. So they're very far along in actually the development of those criteria. They spent a lot of time at the CSS that just occurred last week actually honing in on those, and it's just a matter of now prioritizing them and developing the survey. So that's something that will be undertaken at the European event. Another project that we'll be meeting is the de-identification of ATOM data sets. This is a follow-on to the PhUSE Data Transparency Initiative. That initiative developed a series of rules for de-identifying SDTM data in a consistent way, and this just extends the work to develop a consistent set of rules for the de-identification of ATOM data sets, excuse me. The non-clinical working group will actually be meeting as a whole, and they have a few topics that they're going to address as part of their breakout sessions at the European CSS. Those topics include the working group plans for 2016-2017. They also include a few sessions around regulatory and industry perspectives on SEND implementation strategies. And then finally, if there's some European-specific needs around SEND, they're really looking to have those brought out as part of the sessions that they'll be hosting at this event. And Chris mentioned this, we have a new project that was incubated at the 2016 CSS in the Optimizing the Use of Data Standards Working Group around the development of an SDTM implementation FAQ. So the non-clinical working group has actually developed something similar for SEND, sort of a public forum where SEND implementers can go ask questions and get their questions answered and moderated by a series of experts. So we're trying to extend that to SDTM implementation challenges. There was a few sessions at the 2016 American or US CSS kind of focused around some implementation challenges with SDTM, and there were a lot of commonalities that were identified. So PhUSE and CDISC have an ongoing collaboration. What we thought would be a useful idea is to actually make this SDTM implementation FAQ a joint CDISC and PhUSE project so that we can actually get the challenges and the issues collated in a coordinated manner and then addressed, again, by subject matter experts. So that project will be meeting at the European event. So if you have challenges with your SDTM implementations, please come to the event and bring those forward. And finally, the last project that will be meeting at the European CSS will be a Future Forum project. And if you go to the PhUSE website, there's a whole section on the Future Forum. And this one project around process optimization is focused on defining optimal processes and new ways of working within our industry that will increase collaboration, as well as identify opportunities for clinical programmers to lead and add value. This project will actually use this symposium to further develop a position paper that was produced in 2015 by the Future Forum leadership. So Chris, if you want to go to the next slide. So at this point, this does wrap up our presentation on the outcomes from the US CSS, as well as kind of introducing folks to the European CSS. I don't know if we have any additional questions. It looks like there may be one. Or perhaps I'm now being told that there are no additional questions. So with that being said, I just want to thank everybody for their time attending this PhUSE webinar. This is the last topic for today's agenda. So again, thank you for attending the session, and we'll see you next month. Thank you.